Hoy, kanina pa kayo nag-aaral dyan. Ito muna, mga snacks. Kainin nyo yan.
Okay, tatakot na pala bumagsak sa quiz eh.
Ang cheesy! So yummy!
Ano yun? Risha, ikaw ba yun? Asin eh.
Hoy, hindi ah. Ito kaya yun.
Kung totoo nga, peke nga ako.
O, kahit sa'yo pa yan. Asim?
Roda,
Oh, bakit rigor?
pwede pa abot ng steam.
Oh yan, saksak mo yan. Alam ko bawal ka dyan, di ba?
Aray!
They ask you how you are, you just have to say that you're fine when you're not really fine.
Hi everything! I am Rory, short for sensory. Alam mo ba bakit ka nasasaktan? Ang asim! Alam mo ba kung bakit inaamoy mo, nalalasahan mo rin? Tara! Join me to Sensory Symposium. G ba kayo? Welcome everyone to the Sensory Symposium. Today, we'll explore the amazing sensations that arise from the structures of the oral cavity. Each of my esteemed colleagues will walk us through a different type of receptor.
Hi guys, I'm Lloyd, and I'll be the one to introduce to you the first receptor, which is the taste receptor. So what are taste receptors? These are specific proteins located on the surface of taste receptor cells that interact with taste molecules. They initiate the process of taste perception by sending signals to the brain when they detect certain substances. Meron ding tinatawag na taste buds. So these are structures on the tongue and other parts of the mouth that house taste receptor cells. Each taste bud contains about 50 to 100 taste receptor cells along with other supporting cells. Taste buds are responsible for the overall process of taste perception by collecting signals from multiple receptor cells and transmitting them to the brain via sensory neurons. Next, let me introduce to you the 5 basic tastes: sweet, sour, salty, bitter, and umami. Baka nagtataka kayo bakit walang spicy. Kasi hindi taste ang spicy. According sa isang research, spicy is a sensation of pain daw. It is the result of pain response triggered by certain compounds in food rather than the activation of taste receptors in the tongue. So let us move on to the taste molecules and receptors of the 5 basic tastes. For sweet, their taste molecules are sugars and other certain compounds like artificial sweeteners, and their receptors are T1, R2, and T1, R3. For sour, their taste molecules are acid, such as citric acid in lemons, and their receptors is proton channels like the PKD2L1 receptor, which detects the presence of hydrogen ions indicating acidity. For salty, their taste molecules are sodium ions and other salts, and their receptors are epithelial sodium channels or ENAC. For bitter, their taste molecules are various bitter compounds and their receptors are called T2R receptors. And for umami, their taste molecules are amino acids, particularly glutamate, which is found in foods like meat, cheese, and soy sauce. And their receptors are T1R1 and T1R3. These receptors are similar in structure to the sweet receptors, but are tuned to detect savory flavors associated with protein-rich food. Let us discuss the process on how taste is perceived by the brain. So even before food enters the mouth, olfactory receptors in the nose detect smells that contribute to how the brain interprets taste. As the food is chewed, it will be broken down and distributed throughout the mouth and in the saliva. The dissolved food then enters a small opening in each taste bud called a taste pore, which houses gustatory cells. At the same time, the mastication sends smells into the nasopharynx, which further stimulates olfactory receptors. And, and then, signals sent from both gustatory cells and olfactory receptors are interpreted by the brain as flavors. Why does he transmit to the brain? Detecting nutrients. The brain uses this information to encourage the consumption of foods that provide essential nutrients. Next, guiding dietary choices. Taste receptors help in making dietary decisions that fulfill nutritional needs. Detecting toxins. Many toxins and spoiled foods have a bitter taste, so bitter taste receptors are particularly important for identifying potentially harmful substances. Preparing the digestive system. The detection of certain taste signals the presence of food and can trigger the release of digestive enzymes and saliva. Associative learning. Taste signals help the brain to form associations between certain flavors and their effects on the body. Here are some factors that affect taste perception. So, as people age, their ability to taste often diminishes. This is partly due to the natural loss of taste buds and a reduction in the number of taste receptor cells. The sense of smell, which is closely related to taste, also weakens with age. Next, genetic differences can lead to variations in the number and sensitivity of taste receptors. For example, some people have more taste buds and are considered super tasters, experiencing flavors more intensely, especially bitter taste. On the other hand, non-tasters have fewer taste buds and may not perceive certain flavors as strongly. Genetics can also influence how specific tastes are perceived. For instance, certain individuals have a heightened sensitivity to bitter compounds, like those in cruciferous vegetables like broccoli and Brussels sprouts, due to variations in the T2R receptor family. And lastly, medical conditions such as sinus infection, head trauma, and Alzheimer's disease, as well as medications like antibiotics, antihypertensive, deficiencies in vitamins like zinc and vitamin B12, and lifestyle habits can alter taste perception. Here are two of the most common taste disorders, as well as how to treat them. First is dysgeusia, or distorted taste. If dysgeusia is caused by medication, the healthcare provider must prescribe another drug. If it is due to infections like sinusitis, oral thrush, these conditions must be treated with the use of antibiotics to restore normal taste. And as for ageusia, or total loss of taste, it can be treated by addressing the underlying cause. Supplements for vitamin deficiencies, dietary modification, corticosteroids for cases where ageusia is caused by inflammation, and saliva stimulants for dry mouth.
I'm Christine D. Castellan and I'm going to discuss the olfactory receptor. So what is olfactory receptor? It is a protein capable of binding odor molecules that plays a central role in the sense of smell. So what kind of stimulation is responsible for the oral cavity? The sense of smell, called olfaction, is tuned to detect chemical energy stored in some particular compounds called odorants. The odorants constitute the olfactory stimuli. Olfaction refers to the sense of smell, which begins with specialized collection of cells called the olfactory epithelium. In humans, the olfactory epithelium lines the nasal cavities. The olfactory epithelium contains millions of olfactory receptor cells. These cells have a single dendrite that extends to the outermost layer of the epithelium, where cilia emerge from the end of the dendrite and spread over the surface of the olfactory epithelium. When odorants enter the nasal cavity due to the inhalation or by rising from the mouth during the chewing of food, they stimulate receptor on the cilia, depolarizing the olfactory receptor cells and initiating action potentials that travel down the axon of the receptor cell into an adjacent structure called olfactory bulb. These axons that travel from the olfactory epithelium to the olfactory bulb together make up the first cranial nerve. In the olfactory bulb, the axons of the olfactory receptor cells converge on the dendrite of the olfactory bulb neurons in the small clusters called glomeruli. In these glomeruli, The receptor cells form synaptic connections with several types of olfactory bulb neurons, including cells called mitral cells and tufted relay neurons. Both of these cells project into the olfactory tract, a bundle of fibers that carries olfactory information to the olfactory cortex, where most olfactory processing occurs. Process on how it transmits to the brain. It is important to note that the olfactory nerve is only one component of the overall pathway and is, in fact, made up of multiple nerve fibers or rootlets coming from the receptor cells. The pathway can be summarized as follows: olfactory receptor cells, olfactory nerves, olfactory bulb, olfactory tract, olfactory striae, olfactory cortex, and lastly, output targets of the olfactory cortex. Why does it transmit to the brain? Substances that smell give off tiny molecules. Inhaling moves these molecules into your nose. There are special cells, which are olfactory receptors, detect these molecules. These receptors relay this information to your brain through your olfactory nerve and allow you to perceive smell. Anomalies. First is anosmia, complete loss of smell often due to genetic mutation or trauma. Hyposmia, reduced sense of smell which may result from aging, injury, or chronic conditions. And lastly, dysosmia, distorted smell perception including phantasmia, wherein smelling odors that aren't present, and parosmia, distorted smell of familiar odors. Treatment. Anosmia. There are no treatments for anosmia itself. Hyperosmia. Before your doctor prescribes a treatment for you, they'll need to run tests to make a diagnosis. These tests could include scratch and sniff test, sip, spit, and rinse test, CT scan, magnetic resonance imaging scan or MRI, and endoscopy. Dysosmia. Surgically remove nasal polyps or prescribe antibiotics for a sinus infection. Some experts believe that smell retaining therapy or SRT may help. Clinical significance in the oral cavity. Olfactory receptors in the oral cavity may contribute to the perception of flavor by enhancing the interaction between taste and smell, which is crucial for detecting and enjoying food. Their presence could also influence oral health by detecting harmful substances, potentially leading to new diagnostic and therapeutic approaches in dentistry.
Have you ever wondered how you can feel the texture of food, the smoothness of your teeth, or even the gentle touch of your lips? This is all thanks to tactile receptors. Tactile receptors are specialized nerve endings that detect mechanical stimuli like touch, pressure, and vibration. These receptors play a crucial role in our oral health and daily functions. Let's take a closer look at the different types of tactile receptors found in the oral cavity. Meissner's corpuscles, located in the lips and soft tissues, are sensitive to light touch. They help us detect fine textures and gentle sensations. Merkel cells, it detects sustained pressure and texture, allowing us to feel the surfaces of our teeth and food. Deeper in the oral tissues, Pacinia's corpuscles respond to vibration and deep pressure. They play a role in detecting the forces we apply while chewing. Ruffini endings, sensitive to stretching and tension, also help monitor the pressure during chewing. But what happens when these tactile receptors don't function properly? Anomalies like hypoesthesia or reduced sensitivity to touch can occur. This condition can make it difficult to detect food particles or changes in texture, leading to chewing inefficiency and even speech difficulties. Hypoesthesia can be caused by various factors such as nerve damage from dental procedures, trauma, or conditions like diabetes. A common example is hypoesthesia resulting from inferior alveolar nerve block, Anesthesia, a mild to moderate nerve injury that affects sensation in the oral cavity. Reduced tactile sensitivity can also make it harder to detect food particles or debris in the mouth, increasing the risk of cavities and gum disease. Fortunately, treatments like the use of steroids can help manage hypoesthesia. Consulting with your dentist is crucial to determine the best approach. Understanding the role of tactile receptor in the oral cavity can help us appreciate the complex sensations we often take for granted. If you experience changes in oral sensation, don't hesitate to reach out to your dental profession. But what happens when these tactile receptors don't function properly? Anomalies like hypoesthesia or reduced sensitivity to touch can occur. This condition can make it difficult to detect food particles or changes in texture, leading to chewing inefficiency and even speech difficulties. Hypoesthesia can be caused by various factors such as nerve damage from dental procedures, trauma, or conditions like diabetes. A common example is hypoesthesia resulting from inferior alveolar nerve block. Anesthesia, a mild to moderate nerve injury that affects sensation in the oral cavity. Reduced tactile sensitivity can also make it harder to detect food particles or debris in the mouth, increasing the risk of cavities and gum disease. Fortunately, treatments like the use of steroids can help manage hypoesthesia. Consulting with your dentist is crucial to determine the best approach. Understanding the role of tactile receptor in the oral cavity can help us appreciate the complex sensations we often take for granted. If you experience changes in oral sensation, don't hesitate to reach out to your dental profession.
The next topic we're going to discuss is periodontal receptors. But first, let me introduce myself. I am Tricia Andrea Francisco, and I will be explaining periodontal receptors, their physiological properties, how they transmit information to the brain, their anomalies, and how they can be treated. First and foremost, what are periodontal receptors? Periodontal receptors are sensory nerve endings located in the periodontal ligament. They function as mechanoreceptors, sending signals about tooth loads to the central nervous system during activities such as biting and chewing. These receptors possess physiological properties that enable them to effectively monitor and respond to mechanical forces within the periodontal ligament. They are primarily mechanoreceptors, sensitive to changes in pressure, stretch, and tension that occur during activities like chewing, biting, and speaking. These receptors exhibit high sensitivity to small displacements, allowing for the precise detection of tooth movement and position. This sensitivity enables the receptors to generate action potentials that are transmitted to the brain, where the information is processed to coordinate jaw movements, maintain occlusion, and protect the teeth from excessive force. Additionally, periodontal receptors can adapt to sustained forces, a property known as adaptation, which helps the brain distinguish between transient and sustained stimuli, further refining the control of oral functions. But, how do periodontal receptors transmit information to the brain? First, stimulation. When a tooth undergoes mechanical force, such as chewing, biting, or clenching, the periodontal ligament compresses or stretches, stimulating the periodontal receptors. Next, generation of action potentials. The mechanical changes cause the mechanoreceptors to generate electrical signals known as action potentials, initiated by the opening of ion channels in the receptor cells. During transmission, the action potentials travel along the sensory nerve fibers within the trigeminal nerve or cranial nerve number 5. The information from the periodontal receptors is transmitted through branches of the trigeminal nerve that innervate the teeth and surrounding tissues. Next, processing in the trigeminal ganglion. The sensory nerve fibers converge at the trigeminal ganglion, a cluster of nerve cell bodies located near the base of the skull. The trigeminal ganglion acts as a relay station,
transmitting the signals further into the central nervous system. Next, relay to the brainstem. From the trigeminal ganglion, the signals are relayed to the brainstem, where they are processed in the trigeminal sensory nuclei. These nuclei integrate the information and send it to the higher brain centers. Next is the processing in the thalamus and somatosensory cortex. The processed signals are sent to the thalamus, a key sensory relay station in the brain. The thalamus forwards the information to the somatosensory cortex located in the parietal lobe of the brain. The somatosensory cortex interprets the signals as sensations of pressure, position, pain, or movement related to the teeth and jaws. Lastly, perception and response. The brain interprets the information received from the periodontal receptors, allowing for the conscious perception of the position and movement of the teeth. The brain can also initiate appropriate motor responses, such as adjusting the force of biting or activating reflexes to protect the teeth and surrounding tissues from excessive stress or damage. These are some anomalies of periodontal receptors and their treatment. First anomaly is periodontal ligament thinning or loss. Thinning or complete loss of periodontal ligament fibers can occur due to chronic periodontal disease, trauma, or systemic conditions. The affected teeth may become loose, more prone to mobility, and ultimately may be lost if untreated. Second is hyperplasia of the periodontal ligament. This involves the excessive growth of periodontal fibers, often in response to chronic irritation or inflammation. Hyperplastic periodontal ligament tissue can contribute to abnormal tooth position, difficulty in cleaning the affected area, and increased susceptibility to periodontal disease. These are some treatments that can be done when there are anomalies in the periodontal receptors. First, scaling and root planing. This is a non-surgical treatment that involves deep cleaning of the root surfaces to remove plaque, tartar, and bacterial toxins that contribute to periodontal fiber damage. Next is orthodontic treatment. For conditions like hyperplasia of the periodontal ligament or trauma-induced malocclusion, orthodontic treatment may be necessary to correct tooth positioning.
So now let's move forward to the temperature receptors. So temperature receptors in cutaneous nerve endings are thermostat molecules that induce thermoregulatory behaviors against thermal load. So a temperature receptor is also known as thermoreceptor. It is a type of sensory receptor that detects changes in temperature. These receptors are specialized nerve endings located in the skin, mucous membranes, and other tissues. They send signals to the brain, allowing the body to perceive temperature changes and respond accordingly. What kind of stimulation in the temperature receptor is responsible for in the oral cavity? As for sensations evoked in the other parts of the body, thermal sensations in the face and mouth are subserved by thermoreceptors that respond specifically to cold or warm stimulation and are associated with some of the C fiber afferents. In the oral cavity, temperature receptors detect changes in the temperature of food and beverages. This stimulation helps the body assess whether something is too hot or too cold to consume safely. These receptors are also contribute to the overall sensory experience of eating, influencing taste perception and the sensation of texture. So, for the physiologic properties of temperature receptors are specialized to detect either increases or decreases in temperature. Cold receptors are more responsive to cooling, while warm receptors respond to heating. These receptors exhibit a degree of adaptation, meaning their sensitivity can decrease if the temperature remains constant over time. However, they quickly respond to sudden changes in temperature. Cold receptors typically respond to temperatures between 10 degrees Celsius and 35 degrees Celsius, while warm receptors respond to temperatures between 30 degrees Celsius and 45 degrees Celsius. Outside these ranges, extreme temperatures may activate pain receptors. Temperature receptors are unevenly distributed in the body with higher concentrations in areas like the skin, oral cavity, and mucous membrane, which are more exposed to environmental changes. When stimulated, temperature receptors generate electrical signals that are transmitted to the central nervous system, where the brain interprets these signals as temperature receptors or sensations. The speed and intensity of these signals can vary based on the magnitude of the temperature change. Process on how it transmits to the brain. When temperature receptors detect a change in temperature, they generate electrical signals known as action potentials. These signals travel along sensory nerve fibers with cold receptors using A delta fibers for fast transmission and warm receptors using slower C fibers. The signals reach the spinal cord where they synapse with second-order neurons and are transmitted via the spinothalamic tract to the brain's thalamus. The thalamus processes and relays the information to the somatosensory cortex. In the cortex, the brain interprets the signals as specific temperature sensations, allowing us to perceive and respond to the temperature change. So why does it transmit to the brain? Temperature receptors transmit signals to the brain to regulate body temperature and maintain homeostasis, ensuring that the body responds appropriately to external temperature changes. These signals are processed in specific brain regions, including those responsible for homeostatic control and temperature discrimination, allowing the brain to make necessary adjustments to maintain a stable internal environment. For the anomalies of the temperature receptors, first is Raynaud's phenomenon. This is a condition that causes some of areas of the body, such as fingers and toes, to feel numb and cold in response to cold temperatures or stress. Next is erythermalgia. This is a condition characterized by episodes of burning pain, redness, and warmth in the extremities. Treatment for temperature receptors. In the case of a high fever or a fever that causes discomfort, your care provider may recommend non-prescription medication such as acetaminophen or ibuprofen. Use these medications according to the label instructions or as recommended by your healthcare provider.
Have you ever wondered how your jaw moves so precisely when chewing, speaking, or even smiling? It's all thanks to the muscle joint receptors in your oral cavity, which give your brain real-time feedback on your jaw's position and movement. Muscle joint receptors plays a critical role in proprioception, the sense of body position and movement. These receptors work together to ensure precise control of the jaw movements, which is essential for efficient oral functions like chewing and speaking. Muscle spindles, found in the masticatory muscles like the masseter and temporalis, as well as in the tongue and pharynx, detect changes in muscle length and strength. They provide feedback to the brain about how much the muscles are contracting. Golgi tendon organs, on the other hand, monitor muscle tension and force. They play a protective role by preventing excessive generation during activities like biting and chewing, helping to protect the teeth and temporomandibular joint from damage.
When an action potential reaches the nerve terminal, it causes the release of the neurotransmitter acetylcholine into the synaptic space. Acetylcholine then binds to nicotinic receptors on the end plate. Nicotinic receptors are ligand-gated ion channels. Upon binding to acetylcholine, they open to allow sodium to enter the cells, depolarizing the cell membrane, producing the so-called end plate potential. An action potential is generated in the muscle cell only when the end plate potential reaches the threshold required to activate voltage-gated sodium channels located outside the end plate in the neighboring membrane. When activated, these channels allow faster influx of sodium, further depolarizing and eventually reversing the polarity of the cell membrane. At this point, voltage-gated potassium channels open for potassium to move out, quickly returning membrane voltage to its original resting value. Once generated, the action potential spreads like a wave, thanks to similar voltage-gated ion channels located throughout the muscle fiber. The action potential also runs deep into the fiber via T-tubules to reach the sarcoplasmic reticulum. Here, it activates voltage-gated calcium channels, releasing calcium from the sarcoplasmic reticulum into the cytosol of muscle cells. Calcium then sets off muscle contraction by the sliding filament mechanism. This mechanism is described in another video. Another important component of the neuromuscular junction is the enzyme acetylcholinesterase. This enzyme removes all acetylcholine molecules that do not immediately bind with the receptor, and those that are done activating a receptor. The enzyme action essentially terminates synaptic activation, giving the muscle time to relax and thus preventing continuous contraction that would result in muscle spasms. Substances that cause muscle weakness or paralysis do so by interfering with the function of neuromuscular junction. Botulinum toxin prevents acetylcholine release from the presynaptic side of the junction. Some other toxins attach to nicotinic receptors, blocking acetylcholine from binding but do not open the ion channel. Certain drugs lodge into the channel of nicotinic receptor, blocking the passage of sodium. All these substances prevent activation of muscle cells and cause flaccid paralysis. On the other hand, some pesticides inhibit acetylcholinesterase, preventing degradation of acetylcholine.
But what happens when things go wrong? Experiencing jaw pain or grinding your teeth at night? Anomalies like bruxism, excessive grinding, or clenching of the teeth can overstimulate these receptors, leading to muscle fatigue, pain, and damage to oral structures. And temporomandibular joint disorder, or TMD, affects the jaw joint, causing pain, stiffness, and difficulty of chewing and speaking. So let's explore the effective treatments. For bruxism, mouth guards protect teeth and reduce strain by preventing clenching. They're made from hard acrylic or softer materials to fit comfortably over your teeth. Stress management. Techniques like relaxation exercises can also help reduce tension and prevent grinding. For TMD, treatments like medication and physical therapy can relieve pain and restore jaw function.
Hi guys, I'm Lloyd, and I'll be the one to introduce to you the first receptor, which is the taste receptor. Pain receptors, also known as nociceptors, are specialized nerve endings in the body that detect and respond to harmful or potentially harmful stimuli. These receptors are found in various tissues, including the skin, muscle, joints, and certain internal organs. There are 4 types of pain: nociceptive, neuropathic, acute, and chronic pain. First is nociceptive pain. This type of pain results from actual or potential tissue damage. It occurs when nociceptors detect harmful stimuli and send signals to the brain. It is typically caused by physical injuries, inflammation, or damage to tissues such as cuts, burns, and fractures. Nociceptive pain has 2 types. First is somatic pain, which originates from skin, muscle, joints, or bones. It is described usually as sharp, aching, or throbbing pain. And next is visceral pain, which arises from internal organs and is often described as deep, squeezing, or cramping pain. Next is neuropathic pain. This type of pain is caused by damage or dysfunction in the nervous system, including the nerves themselves, the spinal cord, or the brain. It is often chronic and can be challenging to treat. This type of pain can result from conditions such as diabetic neuropathy, post-herpetic neuralgia, multiple sclerosis, or nerve injuries. It is often described as burning, tingling, shooting, or electric shock-like. It may also involve heightened sensitivity to touch, or allodynia, or exaggerated pain responses to mild stimuli, or hyperalgesia. Lastly, chronic pain. Chronic pain is a pain that persists for longer than 3 to 6 months, often continuing even after the initial injury or underlying cause has resolved. It can develop from an initial injury or illness, or it can occur without a clear cause. It can be constant or intermittent, and it may vary in intensity. It often leads to significant emotional and psychological distress. Examples are chronic migraine and osteoarthritis pain. Following is the acute pain. This type of pain comes on suddenly and is usually sharp in quality. It serves as a warning signal of injury or disease and typically lasts for a short duration. It usually lasts for a few days to weeks, but typically no longer than 3 months. It usually resolves once the underlying cause is treated. Examples are toothache and post-operative pain. Before proceeding to the next, let us summarize the 4 types of pain. Nociceptive pain is due to tissue damage and is usually acute. Neuropathic pain results from nerve damage and is often chronic. Acute pain is short-term and usually resolves with healing, and chronic pain persists over time, often lasting beyond the typical healing period. Dahil merong 4 types of pain, meron ding 4 types of nociceptors, and they are called thermal, mechanical, chemical, and polymodal. First is thermal nociceptor. It detects extreme temperatures, either hot or cold, that have the potential to cause tissue damage. Its receptors are TRPV1 or transient receptor potential vanilloid 1, which is activated by heat above approximately 43 degrees Celsius, and TRPM8, which is activated by cold temperatures below approximately 25 degrees Celsius. When these receptors are activated by extreme temperatures, they generate action potentials that are transmitted to the spinal cord and then to the brain, where the sensation of heat or cold pain is perceived. Chemical nociceptors detect harmful chemicals that may result from tissue injury, inflammation, or external irritants. When chemical irritants or inflammatory mediators bind to these receptors, they generate action potentials that are transmitted to the spinal cord and then to the brain. Next, mechanical nociceptors. They respond to intense mechanical forces such as pressure, stretching, or physical damage that can cause injury. These nociceptors often contain mechanically gated ion channels that open in response to deformation or pressure on the skin or tissues. When a mechanical stimulus is detected, these receptors generate action potentials that are transmitted to the spinal cord and then to the brain. Lastly, we have polymodal nociceptors. These are capable of detecting multiple types of harmful stimuli, including thermal, mechanical, and chemical stimuli. These receptors express a variety of ion channels and receptors that allow them to respond to different types of stimuli. These receptors provide a broad response to potentially damaging stimuli, generating action potentials in response to any combination of harmful temperature, mechanical force, or chemical exposure. Let me discuss to you how our brain perceives pain. First, nociceptors detect harmful stimuli at the site of injury and generate action potentials. Then the signal travels through afferent fibers or A delta and C fibers to the spinal cord. In the spinal cord, the signal crosses over to the contralateral side and ascends through the spinothalamic tract. Then the signal passes through the brainstem and reaches the thalamus. Then the thalamus relays the signal to the somatosensory cortex and other brain regions where the brain perceives the pain. Why pain receptors are important? Nociceptors send signals to the brain as part of the body's protective mechanism. Their primary function is to detect harmful or potentially damaging stimuli and alert the brain, which allows the body to respond appropriately. Since we will be dentists in the future, let us know the significance of pain receptors in dentistry. Pain receptors are very important in dentistry because they play a crucial role in the detection and management of pain in the oral cavity. Understanding the function and pathways of pain receptors allow dentists to effectively manage pain through local anesthetics, which block the transmission of pain signals. There is a theory called gate control theory, proposed by Ronald Melzack and Patrick Wall in 1965. The gate control theory of pain is a scientific theory that explains how pain is perceived and modulated by the nervous system. This theory suggests that there is a gate mechanism in the spinal cord that can either allow or block pain signals from reaching the brain. This gate is located in the dorsal horn of the spinal cord, specifically in the substantia gelatinosa region. This gate controls the pain signals from the peripheral nerves to the brain. And when the gate is closed, pain signals are blocked or reduced. Before we discuss how to manage and treat pain, it is important to know pain threshold and pain tolerance. Pain threshold is the minimum intensity at which stimulus is perceived as painful. For example, kapag hinawakan natin yung mainit na kaldero, the moment we start to feel pain marks our pain threshold. Pain threshold tends to be fairly consistent among individuals, but can vary slightly depending on factors such as mood, fatigue, or stress. So someone with low pain threshold will perceive pain more quickly or easily compared to someone with high pain threshold. Sa pain tolerance naman, it refers to the maximum level of pain that a person is willing or able to endure before it becomes unbearable. For example, kapag nakahawak tayo sa mainit na kaldero, ang pain tolerance is kung gaano natin kayang tiisin yung sakit hanggang sa hindi natin kaya aalisin na natin yung kamay natin sa kaldero. Pain tolerance can vary widely among individuals, and it is influenced by factors such as psychological state, past experiences, and physical condition. These are ways on how we can manage pain. First, we have pharmacological approaches, and under these is over-the-counter medications like NSAIDs and prescription medications such as opioids, antidepressants, and anticonvulsants. We also have non-pharmacological approaches, and under these are physical therapy, acupuncture, and massage therapy. For pain prevention naman, we have lifestyle modifications that include regular exercise, healthy diet, and stress management. We also have preventive medications like vaccinations. And for prevention in dental setting, we have oral hygiene. And last, we have anesthetics. Anesthetics is either pain management or pain prevention, depending on the context in which they are used. For pain prevention, it is used before dental procedures, and for pain management, it is used after dental procedures. Anesthetics has two types, local and general anesthetics. Local anesthetics are injected into gums or around teeth to block the nerves that would otherwise transmit pain signals to the brain. And general anesthetics are less commonly used in dentistry but may be employed for extensive surgeries.